Thank you. So, good evening, all our members of Maharashtra Ophthalmological Society, and especially on our young stars, the postgraduates of Maharashtra, and also who are joining us from the whole of the rest of India as well. From the team of Maharashtra Ophthalmological Society, we welcome you to this postgraduate teaching session. We all know that postgraduates are actually the future of our country, and of course, you are the ones who will be treating us if we develop any eye disorders in the future. So it is very important that you are trained well, and I'm very happy to see that MOS has taken a lot of efforts in this regard. And every month there are two postgraduate webinars in the form of case series, didactic lectures with the help of both state and national faculties that we have who are experts in that field. Usually, there is 1 month which is dedicated to one specialty, and this month we have dedicated this to cornea. So, from MOS, we would like to all welcome all our expert panelists and the mentors who have joined us today as well. So basically, before we go on to the real session, which is coordinated by Dr. Sumit very well, I'm going to invite our president, Dr. Santosh Agarwal, sir, to please give the welcome address, the presidential welcome address, please. Over to you, sir.
Thank you, Dr. Vardhaman. Uh, on behalf of MOS, I welcome you all, especially Sangeeta Madam and all panelists, PGs, mentors, and all my friends and teammates to this unique webinar, which is going to highlight mainly the corneal diseases. And our own PGs are going to present the cases in front of the examiners, teachers, and all the stalwarts. So it will be really a very good learning for the PGs. Few things I want to uh, give as a message to the PGs that in current era, though we are not giving importance to the case history taking or the case presentation, because we have so many equipments or the imaging modalities with us, and we most of us are relying on the results we are getting from the imaging techniques. But mind well, this history taking is very important as far as PG is concerned, as well as practitioners also. They should go in detail and they should take good history. Otherwise, many times overdiagnosis and underdiagnosis of the disease can happen. And also in your exams, the history taking or the case presentation is very important. And I appeal the teachers, respected teachers and the mentors. So you also convey the your PGs, how the exams are taken, what things are expected from the PGs, and also for the PGs, I will appeal that history taking, you go in the details. Don't take it just for the sake of taking. Your examination method should be very proper. That will tell you the differential diagnosis, or 90% time you can come to a diagnosis. And the imaging modalities will aid in the or endorsement. It will give endorsement to your diagnosis. So I think this webinar will definitely give you insight into the how the history should be taken, and how you should approach to a patient. Thank you very much for giving me this opportunity. And once again, I welcome you. Very good, happy new year to you, and very good evening to you all. Thank you very much. Over to Vardhaman.
Thank you very much, sir, for your
Just before
lovely message.
Vardhaman, one quote I have just find out
Yes,
for the PGs. Every time I tell one quote,
yes,
so I
yes.
forgot to tell. Your talent determines what you can do. Your motivation determines how much you are willing to do, and your attitude determines how well you can do. So your talent, motivation, and the attitude all are very important in your PG days. Thank you very much.
Thank you, sir. I think what a lovely message for everybody, especially in this new year.
Inspiring
I'm
for
sure that it
me.
will inspire all our postgraduates for sure. Thank you very much. And of course, it is wonderful to have seniors and mentors like Dr. Murlidhar Ramappa from LVPI and Dr. Sangeeta Wagh from Pune, who are going to teach our postgraduates the best pearls that they have learned through their very long, illustrious career. And also, we welcome all the other coordinators, including Dr. Namrata, to take it forward. So now I would like to invite Dr. Sumit to please take the show forward. And we thank again for being a part of this wonderful PG series this month for Cornea. Thank you very much.
Thank you, sir. Thank you, Vardhaman sir and Santosh sir and the whole MOS for providing this platform for the PGs and everyone. Happy New Year to everyone. And I would like to start with a small introduction. So we have Dr. Namrata Gabra ma'am here. Ma'am is a mentor and a cornea consultant at Ganpati Netralaya. And she is a blessing to all the students who learn from Ganpati Netralaya and every cornea patient who in that area. Ma'am has seen all the cases there. Whenever any patient from the Aurangabad, Jalna, any cornea problem, there is only one person to find, and that's Dr. Namrata ma'am. Ma'am, thank you for being there. And we have Dr. Snehal Thakre ma'am. She is a professor at MGM Aurangabad Medical College. Ma'am is very keen in PG teaching, and she is a very active member of Strabismus Society. And today we have kidnapped her for our cornea program. And thank you so much, ma'am, for being there. We have our mentor, Dr. Murlidhar sir. He does not need any introduction. Sir completed his MD from Bangalore Medical College and did his fellowship from LV Prasad, and he is a consultant there since last 17 years. Sir chose a specialty which is most difficult of the cornea, which is pediatric cornea, and he has excellent knowledge and excellent name in the field. Now I can just say one thing, that he is the go-to person for any congenital corneal opacity all over India. There is only one message dropped to the sir and patient has been taken care. Sir, thank you for being there. And we have Dr. Sangeeta Wagh ma'am. Sangeeta ma'am is one of the very first few fellows of cornea from LV Prasad. She did her fellowship from 1991, and she did her eye banking training also from Baltimore. And since then, she is working in Pune as a cornea specialist. And ma'am has a vast experience in cornea. And thank you, ma'am, for being here. To coordinate and moderate the whole show, we have Dr. Reshma Ranade. She has completed her cornea, cataract, and refractive fellowship from Narayan Netralaya and presently working in Wagh Eye Clinic at Pune under the guidance of Dr. Sangeeta Wagh ma'am. We have our PGs and the main leaders of today, Dr. Kannan. She is a postgraduate exam going student from MGM Medical College. And we have Dr. Radhika. She is a postgraduate student from Ganpati Netralaya. So we'd like to start with Dr. Kannan, her case presentation, which will be followed by the questions and the panel discussion. Dr. Kannan, can you please share your screen?
Yes, sir. Good evening, everyone. Today I'll be presenting a case. The patient, 36-year-old male patient working as a laborer, presented to our OPD on October 22 with complaints of diminution of vision in right eye since 4 months and complaint of foreign body sensation in right eye since 2 months. The patient was apparently asymptomatic before 4 months when he developed the complaint of diminution of vision. He underwent corneal transplant surgery in his right eye for corneal long-standing corneal whitish opacity in the same eye, for which he was started on some topical medications. The patient now had complaints of poor vision and foreign body sensation in right eye. There was no history of redness and pain and trauma to the right eye. Patient had no vision in left eye since childhood following trauma to the left eye, details of which were not known. There was no history of specs use and no history of systemic illness. The sleep, bowel, bladder, and appetite were normal. On treatment history, the patient was started on topical steroids hourly, immediate post-op, which was then tapered to 4 times per day, along with topical antibiotics and cycloplegics. In family history, the family history was not significant. And visual acuity, right eye, it was 616, not improving. In left eye, it was hand movement, PL present, and PR inaccurate, which was not improving on pinhole. Rho plus was negative in both eyes. IOP, which was taken on rebound. In right eye, it was 20 mmHg. Head posture was normal, facial symmetry was maintained, ocular movements was full and free in all cardinal gazes and directions. Visual axis appeared to be parallel grossly as it could not be assessed in detail due to corneal opacity in left eye. On slit lamp examination, eyebrows, lids, and conjunctiva appeared to be normal in both the eyes. Cornea examination, size and shape were normal, surface was normal to smooth. Transparency, corneal graft of about 8 mm was present with central 6.5 mm clear graft, and there were paracentral graft folds present. There was well opposed edematous graft host junction with 16 sutures present in C2 with some broken end suture at 9 o'clock. There was peripheral superficial vascularization of cornea present from 11 to 2 o'clock, which spared the donor cornea. There were no signs of infiltration of sutures, loose sutures, exudate, synecdoche, and pigments on endothelium. The luster and sensations were reduced in the patient cornea. Anterior chamber was slightly shallow with one hairex grading 2. In iris, there were two peripheral iridectomy present at 10 o'clock and 2 o'clock. Both of them were patent. Pupil was 4 to 5 mm dilated under midriatic and lens was clear. This is the picture of the right eye showing. On dilated fundus examination, the right eye fundus appeared to be normal. The left eye fundus was not seen due to opacity. My provisional diagnosis is right eye status post optical penetrating keratoplasty with peripheral iridectomy and left eye vascularized leukomatous corneal opacity post trauma. Thank you.
That was a very well presented case, Dr. Kannan. Dr. Namrata ma'am, Dr. Snehal ma'am, would you have some questions for
Dr. Kannan? You have presented really well. And I would like to know, as this is a very common case, commonly given as a long case in PG exams, practical exams. And I would like to focus on commonly asked questions apart from the case details. What are indications of corneal transplant surgery?
In corneal transplant, this is a kind of penetrating keratoplasty. It can be for support, it is tectonic, and for visual purposes, we have optical keratoplasty, and for therapeutic purposes, we have therapeutic penetrating keratoplasty. And for indications in tectonic keratoplasty, if there is any perforation or corneal thinning is present, then we do the keratoplasty. And for optical purposes, iridocorneal endothelial, then herpes zoster infection, corneal scarring in case of keratoconus, stromal dystrophy, and endothelial dystrophies. In therapeutic, we can do it for pseudophakic bullous keratopathy, corneal ulcers, then aphakic corneal edema, pseudophakic corneal edema, failed graft, failed graft transplant before, Fuchs endothelial dystrophy, and any kind of chemical injury if patient is exposed to in the past.
Kannan, you have enlisted. I would just like to correct few things. Pseudophakic bullous keratopathy and aphakic bullous keratopathy won't come under the heading of therapeutic keratoplasty. Okay. And yes, corneal scar is the commonest reason, especially in India. In Western world, keratoconus is most common. And I would like to know from you how to differentiate between graft failure versus graft rejection.
Acute graft failure is the condition in which the cornea, the graft is edematous, haziness is present immediate post-op, whereas the in graft rejection, immediate post-op, the graft appears to be clear, mostly up to 2 to 3 weeks, after which there are certain signs of graft rejection which are seen. The graft rejection are of, it can be epithelial, stromal, and endothelial. If there is epithelial graft rejection, we can see epithelial raised lines, which if it's on rose bengal stain, it appears to be positive. If there is stromal graft rejection, we can see stromal haze, Kretschmer dots may be present, and
there is something like
Sure.
closed line. It's seen in which type of rejection?
Sorry, ma'am, I cannot hear.
Codadosed line, it's seen in.
Codadosed line is, ma'am, seen in endothelial rejection.
Yeah, so the basic difference is graft failure is because of reasons which are non-immune, and rejection is because of immune mediation.
Mediated. And yes, and
Time
rejection
of
can lead
presentation
to
would
graft
be
failure.
different in both the cases. And you have also elaborated your post-op management, which was applicable for optical graft, along with topical steroids. Even systemic steroids are being given. And in therapeutic keratoplasty, how would you decide post-op management? Or what would be post-op management in case of therapeutic?
In case of therapeutic, ma'am, we need to see if there is, if any corneal ulcer is present or any active inflammation is seen before the keratoplasty. We need to start the patient on certain systemic antibiotics even after the post-op, along with topical steroids and antibiotics.
In case of therapeutic, post-op management should be based on microbiology reports.
Yes.
If it is fungal, then steroids are deferred in immediate post-operative period. There are different recommendations for that. 2 to 3 weeks should be deferred. And if there is any other cause based on microbiology, you have to consider antibiotics. And topical antibiotics is mainstay treatment for post-op management, along with other supportive treatment. And Kanan, just before wrapping up, I would like to know how were corneal sensations for other eye, left eye in this case?
In left eye also, ma'am, they were slightly reduced, but they were present.
Okay. And any history of fever in this patient in past, or recurrent redness in past?
In right eye, ma'am, the patient gave history of redness. In left eye, ma'am, there was no history, as there was just history of trauma in the childhood. Other no history was given by the patient for the left eye.
Because if it's a bilateral case with corneal opacity, herpetic keratitis can be one very likely diagnosis, and especially with sensations reduced. In that case, in post-op management, I would just like to add that we need to add on antiviral prophylaxis even after penetrating keratoplasty. Over to our panelists, experts, and all other members. Thank you. Thank you, Karan.
I think Reshma has prepared certain questions for the panel as well. Reshma?
Yeah.
I just had one question for Dr. Kannan. What is the cause of graft failure?
Graft failure, ma'am, can be due to non-immune causes, like ma'am said. First, it can be due to endothelial.
You have to unmute yourself.
Hello.
Yeah, Kanan, you are audible. You can speak.
Graft failure can be due to immune reactions which may be present, and it also can be due to non-immune reactions. In non-immune reaction, if the endothelium of the graft, like in due to, if there is an aphakic patient, if the vitreous touches the endothelium, it leads to decreased endothelial cell count, which leads further to graft failure. There may be posterior anterior peripheral anterior synecdoche present, which may also lead to endothelial dysfunction, which further leads to graft failure.
Ma'am, you are muted. Sangeeta ma'am. Sangeeta ma'am, you are muted.
So primary graft failure is basically because of poor endothelium and the donor quality, and the graft will not clear right from the beginning. So there is no immune response in this. It's basically because the donor tissue that was transplanted did not carry healthy endothelial cells.
So I have a question for the panelist. Sangeeta ma'am and Muralidhar sir, in the era of lamellar keratoplasties, how much of penetrating keratoplasty hold a place in your practice?
Dr. Muralidhar like to answer that?
Yeah, I think great question. So although, lamellar transplantations have been increasingly performed in the last 2 decades, but a penetrating keratoplasty, particularly in a pediatric age group, most indications when you have a developmental abnormality. And also, as you highlighted, if you have wherever you have a full thickness pathology. So it could be, the post-infection, as Dr. Namrata was pointing out, that's one of the most common indication. Okay. So I think, Kanan, even this particular case, it's worth, looking at, the causal effect for the corneal opacification. It could be, smallpox, or it could be vitamin A deficiency, considering, age of the patient, bilaterality, a vascularized scar. And of course, about the fourth common cause, at least in India, is an herpetic. Otherwise, most are infectious. So the fungus being one of the most common. Second, bacterial. Fourth would be viral. So these are all acquired infections. Nearly 70% of the optical keratoplasty we perform for acquired conditions. Over the years now, particularly for the transplantation for a keratoconus has significantly come down in the last decade, thanks to collagen cross-linking. And most of the endothelial disorders, we do demake or desec. And any pathology which involves full thickness, some of the dystrophies, as you know, even including macular, they're supposed to involve all layers. And we have to really, continue to do penetrating keratoplasty. You asked me a very good question, Reshma. If I can tell you, I've been doing transplantation for the last 20 years. Sangeeta madam doing it for the last 30 years. I think in a long run, penetrating keratoplasty outperform in terms of longevity. I have cases with the 20 years ago I've done a penetrating keratoplasty. They're doing extremely well. Whereas a DSEC, my own DSEC and DMEC, 10, 12 years ago, which I have done. So I had to go and do the re-intervention. I'm sure Sangeeta madam would agree. But of course, lamellar surgeries have the distinct advantage. It eliminates all suture-related complications, quicker refractive, stable refraction, and quicker recovery. Those are all certain advantages. Of course, endothelial keratoplasty, where rejection rate found to be at least 10 times much lesser compared to the penetrating keratoplasty. Each of them, they have an advantage and disadvantage as well. I believe penetrating keratoplasty still has a huge role as a, in our armamentarium as a corneal surgeon.
No wonder they say old is gold, sir.
Yeah, I would like to add on a quick comment on along the same line. I would say in Japan they say longevity. I mean, as they do have longest lifespan, longevity of DSEC is compromised and PKP survives more. The same observation is from Kyoto Group also.
Absolutely.
Also, sir, when do you
compare head-to-head penetrating and lamellar surgeries? I'm sure, Sangeeta madam may be having more than 30 years. I think at least Rao and their grafts. I have seen even a 50-year-old graft, which was done about in the US when Dr. Rao is in Rochester. Recently, I happened to do a cataract surgery in that gentleman. 50 years, unbelievable. Graft has, close to 2,000 cells and doing exceedingly well.
So on that note, sir, when do you shift to low dose steroids following a full thickness keratoplasty, or have you? Of course, you would have seen patients who have stopped treatment after certain years and still they manage to maintain a clear graft. Like you said, you just saw 50-year-old.
Great question. 63% of the penetrating keratoplasty with or without steroid, if they don't have a risk factor, they do well. So this is based on one of the largest systematic review. 63% of the grafts without care, even I'm sure you must have seen, even Dr. Namrata, Dr. Sangeeta would agree with me. Some of the cases where we believe they lost to follow-up, not been on the medications, and doing so well. Recently, I had one child. I had forgotten. 2017, I did a penetrating keratoplasty, bilateral. Child was a 1 year old when I did surgery, and they lost to follow, not medication, anything. 5 years later, they are coming. Both corneas are clear. So this may not be the a true case, particularly when it comes to DSEC or a DMEC. I'll tell you the reasons. Yeah, 63% of them with or without any care, they do well. Remaining, 37% of them need a care. Kanan, if you go back to your picture, the keratoplasty picture. So one is you clearly enumerated all risk factor. So right from the surface, lid adnexa, the corneal surface moisture, and vascularity. If you can just put it in a slide presentation, please. Look at the quadrant of vessels. And these vessels are actually, some of these sutures are also vascularized. So through the suture track, the vessels are also, if you can look at even a superficial vessels are also equally a big risk factor. Okay. And some of the tight sutures, and as you rightly pointed out, even a presence of PAS and glaucoma seems to be one of the independent risk factor. As you rightly said, if we remove, lens, if you convert into aphakic, that is also even a biggest risk factor. So these 37% of the cases where we identify a risk based on the number of quadrants of vessels, indirectly lymphatics, IOP control, compliance to medications, I keep them, if it is uncomplicated case, clean keratoplasty, the 90% of rejections are seen in the first year, and beyond 18 months, you have only less than 10% of the rejection, which I've documented even in a pediatric age group. If the graft survived through the first 1.5 year, then there is a likelihood of it making it for the next 10 years. Okay, provided it has no vessels, no pars, and there are no IOP spikes in that period. So beyond 18 months, as you rightly said, we can switch to. What I do is I'm not a great believer of soft steroid, because as you know, they don't penetrate. And what I do is, beyond 1.5 year, if there are no risk factor, patient really understand your RSVP acronym. So we keep them alternate day. And some of my children whom I have done 18 or 20 years ago transplantation, they are on once a weekly prednisolone acetate. One bottle they use weekly 4 times and discard the bottle. So the rationale behind penetrating, prednisolone tend to penetrate. So there are basically 3 concepts. One is the Langerhans cells on the surface, and you also have ACAID in the anterior chamber, immune deviation. So it is immune privileged status. So the steroid actually helps in maintaining that ACAID. And there are ligand. It's a downstream. It's a mechanistically to explain. It is a little complicated pathway. I generally keep them at least once a steroid dose if there are no contraindication, no IOP spikes or no steroid-induced cataract. So that not only help you maintaining the normal, knowing in adult, every year we lose 0.6% of endothelium annually, right? So whereas following penetrating care lasts 16 years to stabilize and reach that regular endothelial attrition. Great endothelial attrition if you, and then using modular strength one used and indications to have had some
sir, I think there is some internet issue on your side. We are not getting the clear streaming. Muralidhar sir. I think we
I
lost him.
think we've lost him.
Yeah, we should move to the next.
Okay, fine. We can. Dr. Radhika there. Muralidhar sir, welcome back. Can you hear us, sir?
Muralidhar sir, are we audible to you?
No, he's again stuck. Anyway, I will call sir. Sir, can you hear us?
Yes, I can hear you.
Yeah, because we were losing your words and suddenly we lost your video as well.
So, are we audible to you, sir? I think there's a lag, probably.
Yeah.
Yeah.
Sir, we'll move on to another case. I think there is some issue with your internet. Dr. Radhika, can you please share your screen?
Sumit, just sorry to interrupt.
Yes, sir.
Yes. Do you get any questions from the PGs?
I haven't yet, sir. I will just check the YouTube one. On personal and Facebook, I haven't got anything. I'll just check on the
You can
YouTube.
appeal the PGs also. In between, they can put the questions on chat box or YouTube or whatever
I will
number,
do.
WhatsApp number also. So that
Done, sir. Okay, I will put that on a group. Meanwhile, sir. Dr. Radhika. Dr. Radhika, you're there? Reshma, can you continue the discussion? Meanwhile, I'll call Dr. Radhika.
Yeah, sure, sir. So just before we Muralidhar sir, I have one question for you. So many of these pediatric keratoplasty patients that you would have operated, those who have undergone plasties, especially for those which were done for chemical injuries and those which present with persistent epithelial defect, how do you manage this, or what is your protocol like?
Again, great question. Operating keratoplasty. We go see.
So I think the connection is I think there's a little lag in the connection probably. Muralidhar sir, are we audible to you?
Now, is it better? Yes, I can hear you.
Okay, you can hear us? Sir, do you mind if we can Dr. Sumit, do you think we can take Dr. Radhika's case by the time Dr. Muralidhar sir is back?
Dr. Radhika, I just spoke to Mr. Rahul. Are you? Radhika is somehow unable to unmute herself and share the screen. Can you help her do that? Mr. Rahul?
Or we can probably
Radhika,
take a challenging case scenario in between while that is getting sorted.
We can do that as well. Dr. Radhika, please just leave and join the meeting again. I think that will help.
Yeah, I think she's sharing the screen now.
Yeah, screen sharing.
No, she disappeared.
I'll also ask our IT people to help her out meanwhile. Yeah.
I will talk to both of them. Reshma, Dr. Reshma, if you can just start your case scenarios meanwhile, so
Yeah,
we can
sure.
get back to.
Yeah, just give me a minute. Is my screen visible to everyone?
Yes.
Yeah, just give me a second. Just 1 second.
Dr. Muralidhar, am I audible?
Yes.
Yeah. Meanwhile, I mean, she's setting up and doing slide
Yeah.
share. So I thought I'll ask a quick question. Please share your pulse for pediatric keratoplasty. And
Okay. That's a
what
big
percentage
question.
of patients you do consider systemic immunosuppression, steroid sparing immunosuppression, particularly?
Yeah. I think it's a very big question, madam. You know.
Yes, and one more sub question: do you consider role of cyclosporin or tacrolimus topically in high risk cases in addition to prednisolone?
Yeah. So we use a very aggressive steroid. So we use start with almost 10 times, that is every second hourly, and each month. So that the tapering would be monthly tapering. By end of 10th month, we would be using a 10% of original dose. By then, all sutures are out, and I go up to 1.5 year. Thereafter, I would reduce the steroids unless there are contraindications. They would be kept on alternative, sometimes weekly twice or a weekly once. And if the child needs any immunization, or if the child has any viral flu infections, that is the time I advise parents to step it up by 50%. Let's say if the baseline dose, how do we calculate? So beyond 10 months, if it is a first time graft, there are no other risk factors. If the child did not have any other surgery, so the baseline drug is a once a day. If the child has one episode of a rejection, baseline 1+1, one event, we consider as an event, rejection, cataract surgery, if they had a glaucoma surgery, tube or a tab. So sometimes, the baseline drug is as high as a 4 times. We can't, reduce less than that. And thankfully, the last 10 years, I prefer to use a topical tacrolimus, but in extremely, high risk cases, I don't hesitate to use a systemic, both cyclosporin, tacrolimus. Cyclosporin is much easier, madam. They tolerate extremely well, unlike tacrolimus. Tacrolimus, now a lot of companies are providing, the serum estimation and so on. So it's been easier. Otherwise, I'll stick to cyclosporin. Use 4 milligrams per kg body weight in the first 6 months and taper it to 2 milligrams for the next, 1.5 year, meaning totally 18 months. Thereafter, I think they tolerate extremely well cyclosporin children. Then there are few side effects like hirsutism, there is gingival hypertrophy, and by and large, I've seen both adult and children. Children tend to tolerate immunomodulator much better than adults. I think I'll stop here. Yeah.
Any role of topical cyclosporin or any, I mean, tacrolimus?
Yes, tacrolimus.
Consider
Yes.
it, and in which cases?
Yeah, any high risk cases, if the second graft, if have more than 2 quadrant of vessels, if we have done any combined, surgery, if it is a precious one eye, if we have attempted prior glaucoma surgery or a tube, these are all certain, indications for me. And if somebody had, more than 1 or 2 episode of a rejection, so those are the cases where I keep, immunosuppression.
Thank you. Thank you so much. Yes, Dr. Reshma.
Yeah, thank you, ma'am. Thank you, sir. I'll just present a set of challenging cases that we came across in the OPD, and I would love to have inputs of all the panelists for the same. So this is case one. So this was a 19-year-old gentleman who came to us with complaints of redness, watering, and inability to keep the left eye open for the last 3 or 4 months. And when he presented to us, he was on the following medication. He was on canciclovir gel, applying about 5 times a day, and carboxymethyl cellulose drops about 3 times a day. Now, this was what the clinical picture looked like. And to begin with, it was unilateral in the left eye, but it soon involved the right eye as well. So what did we do? So we initially treated him with cyclosporin twice a day and artificial tears. He was symptomatically better, but then over a period of time, his right eye was involved as well. We did a gram stain to rule out microsporidia, which came out to be negative. But we still started him on voriconazole 6 times a day, which was tapered to about 4 times and was continued up to 3 months. So he partially responded to the therapy, but there wasn't a complete resolution. So what do we do next? What is the question that I have in mind? If you could just have any inputs on this, probably. Or is okay, could so this was another 46-year-old gentleman who presented with a wide opacity in the left eye for 8 months. He was AKT in 1997, 2002, and 2004. And there was no evidence of COX on PET CT.
Reshma, your slides
are my slides
are not
visible?
moving. Yeah, now we can see your slides.
Now they are?
Yes. Thank you.
Yeah.
Please.
So sorry for the glitch. Yeah, thank you, ma'am. He was a 46-year-old gentleman with a white opacity in the left eye for the last 8 months, presenting with a diminution of vision. He had a history of AKT, which he had taken in 1997, 2002, and 4, but there was no evidence of COC on PET CT. When he presented to us, he was on Acivir eye ointment 3 times, Predfort, Bromphenic, and oral acyclovir, which he was taking 800 milligrams once a day, and Dorzox. So he was initially treated with linezolid, Vozol, Predfort once a day. He underwent a biopsy at LVPI and he was clinically diagnosed as microsporidial stromal keratitis. Was continued on Vozol and tablet albendazole 400 milligrams was added. Scraping was done. Spores of microsporidia and gram-positive cocci and gram-negative cocobacilli were isolated. And he was then shifted to fumagillin, Vozol 6 times a day, and albendazole, and systemic steroids in low doses. So I have a few questions for the panel, and in the interest of all the postgraduates and young ophthalmologists, as to how would you clinically differentiate between a microsporidiosis and adenoviral keratitis, because many a times they do look similar.
Yeah, Reshma, can you hear me?
Yes, sir, I can.
Yeah. So, so very nice cases. Oh, I think my voice is echoing, isn't it?
Oh, wait.
You're okay.
Okay. So we call it as the coarse punctate epithelial keratitis. It's called a PEK. For a PEK, one of the DDs when you consider first one is a microsporidial and a post-adenoviral, and you also have a thygosens. So microsporidial, 95% of the time unilateral, and along with corneal involvement, you do have a conjunctival congestion. And when you carefully look at both palpebral and a bulbar conjunctiva, you would see a mixed reaction. It could be papillary or a follicular. And very rarely they do have a lymph nodes. And when you carefully look at, they have a history suggestive of a contaminated water. Either they have taken a dip or a bath in a contaminated water. And when we examine cornea per se, these lesions are elevated, intraepithelial. They're like a stuck-on appearance. And so it may be, entire extent of the cornea you can see. When you do a fluorescence staining, you would see a negative staining. That's a way to easily pick it up. And we also have a OCT sign. If you have an high resolution OCT, if you do OCT, the lesions is completely confined to the epithelium and underlying stroma, Bowman's membrane uninvolved, unless there is a complication, unless somebody had inadvertently started steroids. Coming back to sum up, it is always unilateral. Look for the conjunctiva. You have a conjunctival signs and purely limited to the epithelium. They have a stuck-on appearance, and you don't have any scar opacities. And this would actually tells you. And I would do a scraping, not a grams, KOH and KFW. I mean CFW, calcofit white. So you have almost 95% pickup rate. So if you do a KOH, in a grams we tend to miss. Only thing we have to be careful when we do a grams, you have to look at is there any pseudopodia formation. Okay, that's basically how do we differentiate from a candida from the microsporidia. Okay, coming to adenovirus. Adenovirus, it goes into 6 or 7 stages rather. The initial 3 stages in this above the Bowman's membrane, and next 3 stages below the Bowman's membrane when involve the anterior stroma and so on. And you have it is almost 95% of the time bilateral. You have a prior history which is suggestive of adenovirus. Sometimes if they have an active follicles, you may see a petechial hemorrhages and follicles, and typically they develop second or the third week. This is particularly so if they have inadvertently used a steroid, they tend to have a higher propensity to develop. But they've also studies shown that there are certain serotypes. I just forgot the serotype. There are about 3 serotypes of adenovirus. They tend to do you have a 2 distinct form, EKC and PCF. EKC, epidemic keratoconjunctivitis. PCF is pharyngoconjunctival fever. EKC tend to have a much higher predilection to develop a post-adenoviral epithelial keratitis. So here, your lesions may be, they are pleomorphic in sense. You may have a fresh lesions. You may have some lesions, maybe scarring. They keep coming, as you have seen, you use a steroid, they regress. You taper it off, they keep coming. Okay. So my threshold, I generally avoid steroids unless they are, affecting directly visual access. And I have a cornea fellow for the last 11 years. We are not able to wean him off, steroids. He's put on immunomodulator. He has to use a tacrolimus. The moment he stops, he would be unable to operate because, he has in the right eye bang on the visual axis. I think we don't know it's an interplay between the host and the virus. You can't blame on a virus alone because in a certain families you have seen all family members are involved. Only one individual has a corneal lesion. Rest of them they don't manifest this. So completely we do not know the immune biology in such cases.
Okay. So in your experience, have you found that 0.09 or 0.1% of cyclosporin works better as compared to 0.05 for these patients?
No, earlier we used to use a cyclosporin. Because we used to also formulate. We had a pharmacy 1%, 2%. They don't tolerate. Believe me, 2%, 1%. They don't tolerate. And we used to use a restasis. And ever since we've used a tacrolimus, there is no look back. Because there are 2 randomized clinical trial. They've shown tacrolimus and cyclosporin. Tacrolimus is a basically calcineurin inhibitor. It is 80 to 100 times more efficacious than a cyclosporin. So it is a natural choice. You can just apply over the skin. You don't have to put it into cul-de-sac. And 0.1% ointment preparation works extremely well. And I didn't have to, use steroids. Maybe after 4 to 6 weeks later, I just generally keep them on a tacrolimus. It works very well. How long to keep? At least 6 months. There should not be any relapses. That is the safest time we can go on, wean them up at tacrolimus. Okay. And coming to third one, thygosins. Thygosins, again, 80% of the time bilateral. And these lesions, have you shown, they're also, again, stuck on appearance, rise, but they're evanescent. If you keep seeing every day, the lesions are moving. They move from periphery to the center. Okay. and use a one steroid dose. Within 3 to 4 days, they have a striking response. All lesions disappears in a 3 to 4 days. That has to be thygosins. And thygosins never leave behind any scar. And again, these lesions are polymorphic, meaning, lesions of a different age group, fresh lesions, old lesions, they tend to stay. And steroids are the way to go. Again, tacrolimus works extremely well in a thygosins. Okay. So whenever you see a coarse punctate epithelial keratitis, so distinguish it as a bilateral or a unilateral. Unilateral has to be microsporidial. Bilateral, ask for a prior history of adenovirus, and very simple. Okay. Use steroids in a post-adenoviral only when visual access is involved. Otherwise, have a higher threshold not to use a steroid. Because once you start steroids, you can't wean them off steroids. I'm sure, Sangeeta madam would agree with me. Sometimes, we have to years, we have to use the steroids. And thygosins, I have one of the longest follow-up, child, 14 years. So they tend to stay for an extended period. Tygerson himself has shown, 40 years of follow-up, and the lesions were kept coming. They tried, PTK, alcohol epithelectomy, every possible thing, but nobody knows immunopathogenesis. Currently, I have one. She was a medical student from Karnataka, and then she did a residency, from PGI, gynec, and she's somewhere consultant now, 12 years. She again has a recurrent lesion. She always, every 3 months she comes to LVPI. So yeah, again, once you make a thygosins, it's a sort of, lifelong, condition, and you have to keep managing them. I hope I gave some clarity here. Dr. Sangeeta, you want to, from your experience, please.
So in fact, right now, we have on hand one of our patients who I had operated about 17 years ago, bilateral CHED. And like you said, he was doing so well. He recently went to Canada and he was here on a holiday, and he went into some swimming pool, and he's got the keratitis, which I thought was microsporidia. I couldn't identify anything at all. He goes back to Canada, and there a very well-known corneal surgeon is handling him, and he just pumped him with steroids, with acetate, and now he comes back on a holiday and we find his pressures are like 28. So of course I was not able to prove the microsporidia, and the fact is that the opacities have all disappeared, so it's more in favor of an adenoviral than a microsporidia. But that was the other question, like keeping these children on, or any patient of adenoviral, on long-term steroids. We're looking at steroid response, cataractogenesis. But here again, it was a bit tricky to save the graft, and you didn't want to trigger an immune response, a graft that has lasted him over 17 years now. It would be a real, so, he's a steroid responder, and now those opacities have cleared. I'm not 100% sure it's not microsporidia, but I'm not even convinced it's adenoviral. So it's really tricky. And I think, after listening to you, I don't know why I didn't think of tacrolimus, but maybe he should go back to Canada carrying a year's supply of tacrolimus and just go off the steroid.
Yeah, thanks for bringing that case. So I have a few, I think 3 cases precisely referred from. Can you hear me, Reshma?
Yeah, now, yes.
Yeah, in Canada, they have a EBV, Epstein-Barr virus. It's also called kissing disease. And
Yes.
this particular boy, from Bangalore, software engineer, and had a bilateral lesion, went to Chennai, everywhere. They were contemplating AC tap, and they came to me. And we found serologically he had Epstein-Barr virus. So, so the other DD could be an Epstein-Barr virus in this case. It produces exactly similar to the adenoviral lesions.
Also, what is your treatment of choice, and for how long, sir, would you continue with the therapy? And how would you manage patients who are not responding to medical management, like the case which I showed, the first case which we showed?
Okay, go back to that picture, please.
Yeah, sure. Just a second.
You said it is a monoocular, uniocular, right?
Yeah, it's uniocular.
वो disturb
Oh.
कैसे होगा?
Yeah. If it is a uniocular, please look at both tarsal as well as both UTC and LTC. And I would recommend doing again scraping to include all lesions. Go for a KOH and CFW preparation, and remove the lesions. Mechanically debride all lesions. So to me, it looks more of a microsporidial, a very prominent, stuck on appearance lesions, unilateral. Yes.
So actually, this boy did very well with just debridement. I treated him for months. Again, he was studying in some far-off place in Karnataka, and his uncle, who was a practicing homeopath, he sent him. And finally, what worked was mechanical debridement, bilateral, simultaneous. And now he's been okay for the last couple of years.
Microphone Eric, Intel Smart Sound Technology for digital.
Yes, madam. I would recommend. You may be having some practice. Is a water bodies, the overhead tank may be contaminated, and you may be splashing some contaminated water into the kaldi sack. I think if we can talk to him and make sure he changes those lifestyle modification, I'm sure we can. I think to me clinically, Reshma, looking at this case, it's microsporidia. I would agree with Sangeeta madam. Just complete debridement of those lesions. Sometimes one of the child who had been treated with dexamethasone, our own staff, they thought it is an allergy. So our entire family went to pilgrimage and a dip. Following about 4 weeks later, she developed. I had to remove entire epithelium and put a contact lens and monitor them closely. In a week's time, all lesions disappeared. And fumagillin, PHMB, all kind of, neomycin, parmomycin, they've used everything, nothing works, believe me. And it's same with the stromal keratitis. If the biopsy is proven, it is a surgical diagnosis. Please go ahead and do a optical graft as soon as possible. They do very well. Very next day, if you have given a 1 millimeter of clearance, you can go and start steroids. They do extremely well in a long run.
Thank you very much for the insightful discussion, sir and ma'am. I think Dr. Radhika is ready. So, Radhika, can you just share your screen?
Yes, ma'am.
Yes, we can see your screen. I think you can start presenting.
Good evening, all. 17-year-old male resident of Jalna, nursing student, came with chief complaint of painless gradual diminution of the vision in both eyes since 2 months. History of present illness, patient was apparently all right 2 months back when he noticed painless gradual diminution of the vision in the both eye, which was progressive in nature. Patient is habitual eye rubber. Negative history, no history of frequent change of the glasses, photophobia, glare, history of diplopia, trauma, long-term use of topical steroids, no history of night blindness, use of contact lenses, and no history of sudden onset pain and diminution of the vision. Past history of some laser corneal surgery done 1 month before. There is no history of delayed milestone, abnormal joint deformities, cardiovascular illness, and bronchial asthma. Family history, no history of using glasses in the siblings. Personal history, no known systemic illness, no history of morphological abnormalities. General examination, patient is conscious, cooperative, and vitals are stable. Systemic examination, there is no abnormality detected in the any CNS RS for abdo system. Ocular examination, head posture within normal limit, facial symmetry is there. Patient is orthophoric. Then I will enumerate the first findings for the right eye and then left eye. So visual acuity in the right eye 660 with pinhole 6/9, and base corrected visual acuity -4, -7 at 20, and 6/9. And retinoscopy scissoring reflex is present. Extraocular movements full and free in all directions. Leads Munson signs is present. Conjunctiva within normal limit. Cornea normally size. Prominent corneal nerves seen. Mid peripheral mild stromal heads seen. Anterior chamber is deep, iris normal color pattern, pupil normal size reacting to light, lens is clear, and intraocular pressure 14 mm of Hg. Now for the left eye, visual acuity is 6/12 with pinhole 6/6. Best corrected visual acuity minus 1.5, minus 1.5 at 150, which improved to 6/6. Retinoscopy in scissoring reflex is present. Extraocular movements full and free in all directions. Lids, Munson signs present. Conjunctiva normal. Cornea normal in size. Prominent corneal nerve seen. There is conical protrusion with central thinning. Partial annular ring seen at the base of the cone, which is suggestive of the flesher ring. Anterior chamber is deep. Iris normal color pattern. Pupil normal size reacting to light. Lens is clear and IOP is 14 mm of Hg. On fundoscopy, right eye on distal direct ophthalmoscopy, red glow is seen, and for left eye, annular dark shadow separates the bright reflex of corneal, central corneal from that of peripheral corneal, which is suggestive of the oil droplet sign. And fundus of both eye within normal lengths. My probable diagnosis, both eye corneal ectatic disorder, which is suggestive of keratoconus, right eye status post corneal surgery, suggestive of corneal collagen cross-linking. There is slit lamp photo showing the conical protrusion at the center. This is a partial flesher ring seen in inferior. This topography of the right eye, left eye. Thank you.
Very well presented, Radhika. I would request Snehal ma'am, Namrata ma'am, Sangeeta ma'am, and Muralidhar sir, if you have any questions or comments for Dr. Radhika, please.
Yeah, Radhika, well presented. Can you go back to negative history? We have to be in examination very, very careful. Because you did say that there is no frequent change in the glasses. It's unlikely that in a K-conus. Okay, sorry. So negative history. You mean to say there was a frequent change in the glasses? Can you just clarify?
Sir. The negative history that means no history of frequent change of the glasses.
You think it is possible in a keratoconus there is no frequent change in the glasses, considering?
Yes, sir. Because of the irregular astigmatism is there, patient will not be happy for the glasses and frequently visit the ophthalmologist that I'm not able to see clearly, blur vision, and so there is a history of frequent change of glasses.
Then why did you put it as a negative history? Your title shows negative history.
Patient, there is no complaint for the frequent change of the glasses for this patient.
So they do.
You mean to say did?
Yeah.
Sorry. Yes,
No.
continue, sir.
Yeah.
No, I just wanted to clarify the same point, like whether he changed the glasses or he did not change the glasses.
He did not change the glasses. He doesn't give the history for that.
Okay.
Yeah, even if they don't give, you have a knack of eliciting. Leading questions have to be asked in such a way. Parents or a child, I'm sure they would be having. Right? Can you go back to picture? Can you enumerate all clinical signs in a chronological order? Which appears first? Munson's is a very last sign, late sign. So there are about 12 clinical signs. Can you just enumerate all of them?
When will you think of that this patient is having keratoconus? What will you look for? When will you suspect?
So clinically, if there is a spheric astigmatism increases of -1 diopter over a period of 1 year, which is suggestive of the keratoconus. Then Vogt's trial.
Okay. And
flesher ring.
You have yes, and there are a few more signs which will.
On slit lamp examination, there is a conical protrusion of the cornea.
Okay. Any other sign which you see on slit lamp examination, which is late, but it is there on slit lamp examination?
Hydrops, acute hydrops.
Okay, that can be there. Any other sign?
Radhika, sign on retinoscopy, sign which we check with torchlight.
Scissoring reflex on retinoscopy.
And something which we check with a torchlight and
T sign.
Yes. And
Very good.
in fundus, what you explained is known as
Charlock.
yes.
Yes. So you know the science. You just have to think a
Hmm.
little bit.
Yeah,
Hmm?
very good. So in
Yeah.
addition, the first and foremost, you see an abnormal specular reflex in area of protrusion. So this is one of the very earliest. Then as Madam said, just use a retinoscope. You would see the scissoring reflex. You would see oil
Yes.
droplet reflex. Okay. And
Mhm.
stromal thinning. Next, apical scarring. You also said, prominent nerves. You also see a oak striae, right? You have seen a oak striae. If you exert, pressure, they disappear. These are all stress lines. And I'm glad
Yes, sir.
you mentioned eye drops. It can be a very late clinical sign. Okay. We also have to remember, definition. So what is keratoconus? Okay. What is from keratoconus? What is subclinical
Clinical
keratoconus?
period.
Okay. So people, examiner tend to ask these questions. And if you answer all these questions, there are some people who know systemic condition. There are at least 25 syndromes which are associated or tend to have a keratoconus. Can you name few, at least 5?
Yes, sir. Down syndrome, Ehlers-Danlos syndrome, Marfan
No,
syndrome.
no. So
No,
that's
no, no.
connective. You should not say those things. That's a keratoglobus. So the commonest is LCA. You must have.
And
Yes, sir.
Leberus,
ocular associations.
yeah, there are a lot of.
VKC, ma'am, vernal keratoconjunctivitis,
And
Leber's congenital amaurosis.
Correct.
Then,
Yeah, that should be fine.
retinitis
Yeah.
pigmentosa.
so now suppose this patient has come to you and then you suspect there's keratoconus. Which investigation will you go for?
Topography, ma'am. The
Very
central
good.
corneal thickness.
So what signs will you see classically on topography?
On topography, ma'am, there is a superior inferior asymmetry with skewed
And
radial axis. If it is greater than 21 degree, it suggestive of the keratoconus.
anything else? What are these Rabinowitz criteria?
Rabinowitz criteria is KISA index. They give keratometry.
Something, no. That is those you were telling the first, na? Are there any other parts of? There are 3-4 criteria.
Yeah,
So
it is
one you
three.
have told.
Yeah, it's basically 3 criteria.
Keratometry greater than
Yeah, K value.
47.2
First is a
diopter.
K.
K value. Then there is greater than 47.2 diopter, ma'am.
Yes.
Yes, ma'am. Then secondly, if there is a superior inferior symmetry greater than 1.4 diopter, the oblique astigmatism greater than 1.5 diopter, and skewed radial axis greater than 21 degree.
Okay. So what's the differential diagnosis before that, how you grade keratoconus?
According to the keratometry, if mild, moderate, severe, and advanced. If mild, then keratometry is 45 diopter. Then 45 to 52 is moderate. Greater than 52 is severe, and greater than 62 is advanced.
That is a pretty old one. Anything new, There are many gradings, but anything more recent?
Ma'am, for progression, Amsler-Krummek classification.
That is a very old one, 1972.
Anything else still new with your topography?
It's new and its name is very
5.9
very alphabetical. Something which is
ABC.
Yes. Yeah, ABCD is the most accepted, very robust, very robust grading. So you need to have a tomography, not topography. Either, pentacam, okay?
Okay. So what's your differential diagnosis for this?
Pellucid marginal degeneration, keratoglobus.
So how will you differentiate between them? Yes, you are.
Pellucid degeneration is inferior 4 to 8 occurs, thinning is present, and above that there is a protrusion, and it is present in the 20 to 40 years of the age group, PMD.
And which age group does keratoconus
and in the keratoconus in puberty. And in keratoconus, there is a corneal protrusion, inferonasal or inferotemporal. And flessuring, Hochstripe, most prominently seen in the keratoconus, not in the PM.
Okay. And can you give a management protocol for this keratoconus? How do you go about managing once you diagnose?
Yes, first, we give the spectacle. And then we can go for rigid gas permeable contact lens trial. And there are new contact lenses also, Rhodes, and Brodsky, and scleral contact lenses.
Anything else beyond that?
Collagen cross-linking, deep anti-lamellar keratoplasty.
In whom you will do collagen cross-linking? In whom will you do collagen cross-linking? In which patients will you do collagen cross-linking?
Corneal thickness should be greater than 400 micron is one of the indication. And if the progression is there on topography.
So what is the role of collagen cross-linking?
Collagen cross-linking, it creates the strong chemical bond between the collagen fibrils of the stroma, which will strengthen the fibers of the stroma and stop the progression.
Yeah, so basically it stabilizes the progression. It stops the progression.
Biomechanical property of the code. Yes, ma'am.
Yeah. And when will you do going for DALK and all? DALK, what is the indication for DALK?
DALK, if there is a stromal opacity is present, deep stromal opacity.
Okay.
You did well, Radhika. I have a few questions for the panel, ma'am. If you could.
Sure.
Yeah, please.
Sangeeta ma'am, Namrata ma'am, what is your go-to technique for DALK? Do you prefer the big bubble or do you prefer manual dissection?
So I think, Namrata, go ahead.
No, ma'am, please go ahead.
So, well, it's everybody's dream to do the big bubble technique and get a clean decimus. But there are, like, if there is a dense scar and a apical scar, I would be a little careful. Again, if a patient has undergone cross-linking and progresses, then getting a big bubble is quite difficult, and it might be simpler to try a manual or plan a manual. But besides all this, I think what is important is that at the back of our mind, we need to keep in mind that you might need to convert at any stage. So it's a good idea to keep an optical tissue also at hand and see how it goes. Once in a while, you may not get the perfect big bubble, in which case you have to be mentally ready to accept defeat and go for a manual DALK, so that even if you leave a little sliver of stroma, there's no bravada, and not getting a big bubble is better than perforating. So like I said, unless it is obviously difficult because of scarring or because of previous cross-linking, my attempt would be to do a big bubble. And of course, there are different techniques that are described. Even in the manual, you can go layer by layer, or like Dr. Rishi Swaroop has mentioned, the groove and strip, that also works well. So these are the different techniques which I would attempt.
Very true, ma'am, because N-DALK and D-DALK, what they say, near desmatic DALK and desmet bared DALK, result-wise or visual acuity-wise, they perform equally well, though theoretically chances of rejection are little higher with some residual of stroma. Let me tell you, I am a die-hard fan of groove and peel technique. Because it has less chances of burning your fingers. I have burnt my fingers in some of the cases initially, and as you rightly pinpointed, especially cases with corneal scar, big bubble, I won't attempt big bubble if there is corneal scar. I would directly opt for groove and peel technique.
Muralidhar sir, in your practice, how do you think that management of KC largely differs in children and adults per se?
Yeah, the great question. I think Dr. Sneha madam was asking, the 14.1 year is a mean age at presentation of keratoconus in our population. Now we've been increasingly using tomography. So youngest I have diagnosed keratoconus 5-year-old. So we are now able to pick up much earlier. Okay, and these children, tend to progress also because their cornea is more elastic. There is no age-related collagen cross-linking, and hence they tend to progress much faster. So as Dr. Sangeeta said, extreme keratoconus, prior eye drops, and significant scarring. And if you have a globular variant of keratoconus, where I tend to do a manual dissection. So manual dissection equally good, and it will give you predesmetically, dissection. It will give even a graft-host junction much more stability compared to the desmids bearing, that is supradesmetic. So otherwise, thankfully, we would be able to get a big bubble in most cases of moderate cases of, keratoconus. I think because of collagen cross-linking, now my indication for a keratoconus doll has come down significantly. Only overseas cases are the one we do, normally, lamellar surgeries. People from Mid Asia, West Asia. Okay. So otherwise, rest all are a routine thing. And also, even if you end up doing a PK, they have extremely good outcome. Okay. So there is no need to feel, we could not get a big bubble, or we get something like lamella, which is maybe a little inferior. Even a full thickness keratoplasty works extremely well in these cases.
And usually, I don't know whether this experience is common with all of you. If patient undergoes penetrating keratoplasty in one eye and DALK in other eye, especially keratoconus patients, patient is always happy with the eye where penetrating keratoplasty has been done. The surgeon is happy seeing DALK and the patient is happy seeing PKP.
Absolutely, madam. Absolutely. Because their aberrations, that corneal aberrations are much, much lesser.
Interface is not there, so
quality of vision would be definitely much better with the PK.
Also, what is all of yours experience with repeat cross-linking?
Okay. Thank you. Nice questions. I have done only in 2 cases. First time, this was referred from Seattle. Dr. Ardley, you must be knowing. Then, in the US, they didn't have access to collagen cross-linking. The child was 5-year-old. We did the first collagen cross-linking, followed them for the next 5 years. And thankfully, this family relocated to Hyderabad to take care, child, progress, everything. And again, by 10th birthday, I have to repeat. Okay. So I think, maybe 2 or 3 cases I've done. Otherwise, I don't have to repeat. Dr. Sangeeta, you have?
So yeah, even we have repeated about in 2 patients, but it's also known that the collagen turnover time is something like 8 to 10 years. So I mean, starting from 4 years, but we can expect progression, especially when we the small pediatric age groups, like, if we're cross-linking them, the lowest I have done is 10 years. But I don't know the other panelists, but we see that, in about 8 to 10 years, they do come. Some of them are lost to follow-up, but we do find a regression or progression in some of them. And then that's where I wouldn't hesitate to do a repeat cross-linking. But again, like Dr. Muralidhar said, the numbers are very few, fortunately.
Correct.
And I think when we were doing the Dresden protocol, I saw much less of repeat cross-linking, and with the accelerated that we are all switching to, I think we might expect more of progression and repeat cross-linking.
Yes. I think absolutely well said, madam. You need to have a good residual stroma. Don't wait for, cornea to thin 400 micron. The moment you make a diagnosis keratoconus, if it is a teenager between, 5 to 10 years, your threshold should be so low. So there are hardly any complication. One thing, you may have a corneal haze, sometimes very rarely epithelial healing issues, but children tend to do extremely well. And I think, collagen cross-linking is way to go. I would agree with, the traditional Dresden protocol, that is very robust. You can also clinically notice that, the stromal changes collagen cross, you can see a sort of striae and demarcation lines also we can identify. So that really works very well. I think this all trade-off, accelerated epithelium on, yeah, I don't believe in that. Agree completely. And if they have a VKC, please ensure we take care VKC, eye rubbing and so on. That is a vicious cycle.
Ma'am, sir, I have a question for panel and everyone here. So what is your thinnest of threshold for doing cross-linking? Is it 380, 370, 350? Like below which you will say no to cross-linking and instead go ahead with the DALC or a keratoplasty, whatever it is.
So I haven't cross-linked below 350, and that too with hydration, but there are newer normograms that allow you to do thinner corneas. What will actually prove the test of time would be what happens to the scarring, what happens to the endothelium. And I don't know if anyone has seen post cross-linking iritis coming up in thin corneas. So these are the few things I would worry about. But I haven't gone lesser than 350.
I haven't gone less than 375, and that too with 375 to 400 window, we would go for hypotonic. And before opting for option of DALC, we would definitely would like to try contact lenses. And what I feel is a need for DALC has gone down because of availability of variety of contact lenses as well, because those patients who are not eligible for cross-linking, at times they might remain stable and might not progress and might do well with contact lens as well. So that is also a very good weapon in our armamentarium, apart from DALC.
So, Muralidhar sir, can you hear us?
Yes.
Sir, my question for the panel was, what is the thinnest threshold for your cross-linking below which you don't do cross-linking? So for Sangeeta ma'am, it's 350. For Namrata ma'am, it's 375. What is your take, sir? Especially the kids between 10 to 12 years of age.
I think it's ideal to have a more than 400 microns because
Sir,
we are not
hear
only interested. Oh, okay. Can you hear me now? No?
Now it's better. Yeah, it's better. Yeah.
Yeah. I think I like to have, as I said, so the moment I diagnose progressive keratoconus, I don't wait until cornea to, go down, sub 400. I would go ahead and do as soon as possible. So the thinnest I've done, I agree with Dr. Sangeeta, 350 microns, where we use a hypotonic, but you will run a risk of having a corneal edema postoperatively. You will run a risk of having a progression or a recurrence of keratoconus even after collagen cross-linking. The beneficial effect or efficacy of collagen cross-linking comes down with the thinner cornea.
So when I asked this question particularly because I had a patient who had a Kmax value of almost 78 and 80, and her unaided vision was finger counting 2 meters and 3 meters. So for one eye they were not willing, so we did cross linking, but another eye I could convince them for DALC. Now her unaided vision becomes much better. It becomes almost 624. So in that practical aspect, though we have a good protocols now to do a sub 400, but having a very steep keratometry may not give them a good unaided vision with the cross linking.
True. Absolutely.
So I just had one case, sir, which we saw yesterday in the clinic. So he's a 9-year-old boy who we didn't have any topography of the previous place that he had gone to. But when he had presented at a clinic last year, his refraction was somewhere like a -1 cylinder in both the eyes, and he was improving to a best corrected visual acuity of somewhere around 612 in both the eyes. And when he came to us the other day, his refraction read. So this was the first time we did a topography, and he had like a grade 3 keratoconus in the left eye and a grade 2 in the right. But his refraction had shown a massive jump from, accepting a -1 cylinder to a -5 and a -6 in the other eye. So my question to the panelist is, are we looking at an aggressive progressor here? And of course, we've advised a cross-linking for him. But do you think there should be something else that we should be doing? I have, of course, taken the history of eye rubbing, and doesn't seem to have any signs of VKC and denies eye rubbing. Not that I saw him rubbing eyes while he was, sitting in the clinic talking to me. But do you think that we should be doing something else, or should our antennas be up regarding whether he would progress, or is this a possible patient who would need a repeat cross-linking?
So obviously he's progressing very rapidly, and first thing is to try and cross-link him and try and arrest it. Whether he's going to need cross-linking again or not is hard to tell. But basically, what I would like to ask Dr. Muralidhar is, have we been able to identify any predisposition, any genetic factors, or any epigenetic factors that cause some to progress very rapidly and some don't progress? So often you find you treat one eye with cross-linking and the other eye stops progressing. So have you been able to find anything common that decides or is it, AI will tell you, can AI help us in predicting which ones are going to progress? And are there any other factors or parameters that can give us a guidance?
I think it's a great question.
Why some progress so rapidly and some don't?
I think when we look at the causality for the keratoconus, it's a multifactorial. As you rightly said, epigenetics. Now in US, last academy meeting, I was invited to deliver some pediatric talk. In the same, they were actually doing a lot of genetic analysis now. So there is one company by name Avesta, so which has a panel for a keratoconus. I was surprised. So they screen about 57 known genes so far. And I don't know, we can link directly, or it is a temporal association between those genes and a keratoconus. I have really no clue. But industry and people tend to have that commercial aspect. Again, it's a pretty expensive tool. So they're doing all kind of, they're doing tier markers, they're doing genetic things. I think there has to be some vulnerability, susceptibility. Not everybody who rubs eye rubbing will develop keratoconus. And I think there are many things, madam. I think I have had some siblings having, both of them having a keratoconus. I have had twins, identical twins having a keratoconus. That definitely explain your point. There is a genetic basis truly, but we don't completely yet understand pathogenesis.
Could there be a nutritional aspect? Because
I don't know, madam.
There are, studies which talk about vitamin D and B12, but if you see, the average Indian is low on vitamin D. So we're not sure about the cause and effect. But, even when you're touching these patients' corneas, you see just so soft and buttery they are. So, I think we need to look at really what else could be causing it, and why is it so much more in the sub-Saharan belts, like in Asia and India particularly. There's so many keratoconics who don't have any signs of allergy at all. They don't have signs of eye rubbing. And we're seeing older and older patients presenting with keratoconus, where earlier it was like early childhood or adolescence or teenage. I'm seeing some who are like 30 plus. So, there's obviously some shift that is happening.
Yeah, true, madam. I think Vanati has put in one of the review article where I reviewed that particular article for the postgraduates. It's the last year. If you all can, get access to that article, and it's been elucidated right from, as Dr. Sangeeta pointed out, right from hormonal influence, gender factor, certain family, genetic basis, everything exhaustively covered. When I
Is that in
reviewed
IGO?
that, yeah, that's an IGO. When I reviewed, I have to go through so much of literature, and it was so much revealing for me also personally. Right from thyroid, every hormone seems to have an influence.
Mm.
Yeah, it would be good to worthwhile reading for particularly postgraduates.
Along same line, I would like to add on two simple quick points. One is there is one article on global consensus on keratoconus in Cornea Journal, and to my wonder, there was only one single point where there was consensus throughout globe is eye rubbing is associated with keratoconus. So it's very, very important. You counsel everyone, especially your keratoconus patient, not to rub your eye, not to rub your eyes, because it's very, very important. The causal effect has been kind of clinically established. And secondly, I would like everyone, all the PGs, to go through one more article, is 5-point nomogram by Narayan Nitralay. So they do quote all the risk factors, lower the age, lesser the age, presence of VKC, associations. So apart from the one single definition, if there is progression, you have to cross link. Apart from that, there are patients at high risk which needs to be cross linked, and all those high risk category patients where there is high risk of progression has been categorized well in that article. And it was a treat to learn from Dr. Murlidhar sir and experiences of Sangeeta ma'am. Thank you so much, MOS. And in introduction, only one introduction is left over, was Dr. Sumit's. I think all of us, we are really thankful to Dr. Sumit, because it's a great platform learning for PGs as well as an interesting discussion for all of us. Thank you so much, Dr. Sumit.
Thank you.
And
Thank you, Namrata ma'am.
Yeah.
Thank you, Snehal ma'am, Sangeeta ma'am, Dr. Reshma and Muralidhar sir. Thank you everyone for being here, and special thanks to Dr. Kannan and Dr. Radhika. We know the residents are the most busiest people in the hospital. Still, they took out time in a week's notice and made these cases possible. They did dry run also with us, and thank you so much for being there. Of course, thanks to MOS, Vardhaman sir, Aditi ma'am, Santosh sir, and Atul sir for always being there and supporting all these PG programs. Namrata ma'am and Muralidhar sir, I will take those articles from you. We have a MOS PG group of almost 270 residents. We'll post that on the group so even they have access for the same.
Absolutely.
So with this, I would like to thank again everyone for spending their time with us, and thank you all the PGs for being here, and thank you Entod, of course, for sponsoring all this.
Thank you so
and
much.
good night.
Thank you.
Thank you.
All the
night.
best to PGs.
Yeah.
Thank you. Good night.
Thank you. Thank you, everyone.
Good night. Thank you.
Thank you, Sumit.
Thank you.
Sir. Thank you, everyone.
Thank you.
Thank you. Thank you, everyone.